Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our webinar. This evening, we're going to be talking about strategies on how to treat acne in richly pigmented skin. As speakers, we have Dr. Charles Lin, who is Chief Medical Director at the Lind Institute of Dermatology and Linderm Research, as well as Associate Professor, University of Toronto and Department of Medicine. We also have Dr. Andrew Alexis, Professor of Clinical Dermatology at Weill Cornell Medical College in New York City. We would like to thank our supporter, Cypher, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of the screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this very short survey. Within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will be emailed to you. Again, if you want to submit questions to our faculty, please type in your question in the question chat pane on the right-hand side of your screen. And I wrote you a little note there so that you can see where you need to type in your questions. We'd like to disclaim that the opinions expressed in this presentations are that of the presenters. They do not necessarily reflect the opinions of Cypher Pharmaceutical. So without further ado, I will pass the floor virtually to Dr. Charles Lind.
Thank you very much, Roxanne. And welcome to the evening on talking about treating acne and richly pigmented skin. I thought I would like to start with a initial polling question here. And before we begin,
we passed the polling question.
Yeah,
there we go.
There's the polling question. So I thought just to gauge the kind of interest in the people that have on the line here. So what percentage of your practice is in richly pigmented skin? And I think all of us practice in areas such as Vancouver, Toronto, Montreal. And so we're seeing more and more of this. So please vote. Yeah, so there are some people that are 0 to 15, but you can see in the middle that there's a considerable amount of people that if you probably average this all out here, that you're going to be 40% of our practices are now in richly pigmented skin. We'll now move on. So treating acne in a richly pigmented skin. This is a webinar. Oops, backwards here. This is an acne webinar series that in conjunction with Cypher Pharmaceutical and RBC Consultants have been on. And just to remind you, these are some of the topics that we've talked about in terms of acne. Acne in the time of COVID, it was given by Dr. Jerry Tan. What's new in adolescent dermatology with Dr. Larry Schachner from Miami. Burning out acne, real world cases, Jaggi Rao from Edmonton. Acne and antibiotic resistance, Dr. Lynn Gunther from London, Ontario. And tonight we have a world expert talking about treating acne in richly pigmented skin. So just to remind you, this is kind of where I grew up in dermatology. And you can easily find on the net all kinds of photographs, and they're almost always in Caucasian type of skin. And this, when I was putting this together, these were all easily found on the net. However, finding pictures for people of richly pigmented skin proved much more difficult. We had to go to a number of sites to try to find representative type of cases. So just talking about Canadian statistics, in 1996, 11.2% of the census respondents in Canada reported identifying being a visible minority. And you can see the different options there as being a visible minority. South Asian, Chinese, Black, Filipino, etc. 20 years later, 2016, 22% 3% of the census respondents reported identified as being a visible minority. And projections by Statistics Canada is likely this will increase to somewhere around about 33% by the year 2036. So certainly our population in Canada is changing greatly. And as dermatologists, we have to take this into recognition and to be able to treat these patients properly. And just by the way of things, Statistics Canada is still exploring other language for the next census. They've used the same term over the censuses up to 2021 just because of consistency, but they're trying to find proper language that will identify this in a much better fashion. So we know that acne is very common. It affects 2 million Canadians, affects all age groups, and as we talked about, it certainly affects patients with richly pigmented skin. A lot of emotional and social impact of acne can be significant, and particularly in richly pigmented skin, because often the post-inflammatory hyperpigmentation is much greater, and also keloidal changes, making it a much more impact for a number of our patients. And again, there's actually few papers published on this. When I went looking and everything else, one review identified acne vulgaris as the most common dermatological issue for Afro-Caribbean individuals. Another big US study of about 3,000 patients reported that acne in Afro-Americans and Hispanic women was much, much greater than Caucasian women. And certainly, obviously, the impact, not only the prevalence, but the impact of the disease. I put this in here just in case you missed it. This is a significant thing for the University of Toronto, and I think for dermatology in Canada and actually the world. I believe this is the very first chair that's being established on ethnodermatology. And again, it's with the foresight of our chair of dermatology in Toronto, and AbbVie kicking in $3 million to establish this chair. That inaugural chair will be appointed in 2024. And it basically looks at a lot of different things. They're going to revamp the whole curriculum of dermatology in Toronto, looking at what's in textbooks, evaluation scores for things like acne, evaluation scores for atopic dermatitis, and again, getting models that will reflect this particular group. So it gives me great pleasure to introduce our world expert, Dr. Andrew Alexis, and a great privilege to be able to say so, because he is. And many of you know him as the son of Mercy Alexis, a good dermatologist here in Toronto. Andrew flew off to the States. We hope to get him back, and maybe we'll get him for the first chair of ethnodermatology in the University of Toronto, although he's doing a great job as professor of clinical dermatology in New York. Andrew is, I've known him since being a small boy. He went to many of the Canadian Derm meetings, played with many of my kids. A great guy. He's come back a number of times to speak at Derm Update, at the CDA. And so I'm looking forward to his lecture tonight, and I hope all of you will learn a number of things. I always do. I had the privilege again of being at the Winter Clinical in Hawaii, and Andrew gave a great lecture on richly pigmented skin or skin of color in atopic dermatitis. So we're looking forward to his lecture tonight on acne. Andrew, you've got the floor.
Well, thank you, Chuck, for that warm and personal introduction. It's always a pleasure to spend time with you. I wish we were in person in Toronto right now, but I'm coming live to you from my office in New York. Thank you to everyone who's tuned in tonight. And as a Canadian whose mom is a dermatologist in Toronto, it's always special when I get to present to a Canadian audience. So thank you for the opportunity. I'm going to see if I've got control of the slides. You just never know. Oh, there we are. Great. So I'm going to spend the next 20 minutes or so giving a broad overview of some of the differences, the nuances in treating acne in richly pigmented skin with a focus on getting the best outcomes for this patient population. So when we look at the disease state acne itself, and look at the epidemiology, when any available prevalence data, as well as databases of the frequency of diagnoses that are made in the ambulatory care setting, we see that acne is the #1 diagnosis across multiple populations with skin of color, including, this is all US data, including African American, Asians or Pacific Islanders, Hispanic or Latinos. In this survey of US ambulatory sites, acne was the #1 diagnosis across these populations. In 2022 and throughout, since the pandemic, we've all observed interesting shifts in the type of acne that we're seeing, including mask-induced acne, and this has affected patients with richly pigmented skin disproportionately, given some of the demographics in the healthcare workforce. So we're going to pause with a quick polling question. And that is, which of the following are statements about treating acne in richly pigmented skin are true? First, clearance of papules and pustules is the top priority. Or second option is resolution of both active acne lesions and PIH is desired. Third option is avoiding retinoids is recommended due to irritation. Fourth option, a higher threshold for oral agents is recommended. Or the fifth option, which is benzoyl peroxide should be avoided due to risk of bleaching. So go ahead and submit your best answer. All right, so let's see how we did. So we have the overwhelming majority, 69% of the audience, saying that the second option, resolution of both active acne lesions and PIH is desired. And in the rest of my presentation, I hope I'll convince the remainder of the audience that that is indeed the correct answer. So first and foremost, one of the key nuances to treating acne and skin of color or patients with richly pigmented skin is that the patients may find the post-inflammatory hyperpigmentation to be the most bothersome or worrisome aspect of their acne. It's often the driving force for them to make an appointment and see us. And so in many cases, it's even more problematic to the patient than the acne itself that caused the PIH. It's safe to say that PIH is often either equal or even greater in importance to the patient as the acne itself. So we see the striking differences in the clinical presentation of acne with respect to this concomitant feature of post-inflammatory hyperpigmentation, which is extremely frequent as a sequela in skin types 4 through 6 compared to lighter fit skin phototypes. This PIH, while is a natural sequela, a sequela that cannot be avoided in many cases, when we also add traumatic factors such as excoriation, and other manipulation of the lesions, popping, squeezing, traumatizing the lesions, we can induce even worse PIH, including hypopigmentation within the center of lesions. Post-inflammatory hyperpigmentation can also result as a complication of either prescription or non-prescription therapy used for acne. In some cases, like in this case, it's induced by things the patient may be doing on their own before seeing us and getting expert advice as to the management of their acne. A few years ago, we looked at a web-based cross-sectional survey. We performed a web-based cross-sectional survey of over 200 women with facial acne. And what we found supported our impressions just from clinical practice that over a quarter of our non-white cohort in this particular study reported that post-inflammatory hyperpigmentation was the most troublesome sign of their acne. And this, by comparison, in the white cohort from this study, the most frequent response to the most troublesome acne sign was bumps full of pus or pustules. So The most frequent reported response to this question among our non-white patients was PIH, which speaks to the importance of PIH in the patient populations with skin of color. It follows from the same study that, and I'm having trouble going back a slide. Here we go. See if I'm able to do that. There it is. In the same study, just about 42% of non-white females in the study reported that post-inflammatory hyperpigmentation clearance of the PIH was the most important goal of their treatment. So with that in mind, it is a very useful strategy to convey to the patient that you're going to put together a regimen that will address both the acne and the post-inflammatory hyperpigmentation concurrently. And that way, the patient knows that you're on board with what's important to them, not just the acne, but also the post-inflammatory hyperpigmentation. And with respect to managing the PIH, I will let you know about a recent review article that reviews the literature very carefully about what we know about the pathogenesis and management of acne-induced PIH and offers some recommendations. And when it comes to managing this type of PIH induced by acne, we're fortunate that one of our mainstays of acne, the retinoids, are also useful for treating PIH. So the importance of retinoids in managing acne-induced PIH has been known a long time, including this landmark study from the 90s using tretinoin. One caveat here from this particular study, 50% of these patients did develop an irritant dermatitis to 0.1% tretinoin cream. So that's something to keep in mind with respect to tolerability issues, and we'll talk about that. But since that initial landmark study, there's evidence for using the other retinoids as well as in managing PIH, including tazarotene, adapalene. We've observed some of the newer adapalene fixed combination products, although it's not been formally studied for PIH. And there are a number of newer retinoid options that offer better tolerability than some of the first generation retinoids. And these are now also being looked at for the management of PIH, and more data is needed, but this is an area of growing interest. Included in that is the 4th generation topical retinoid trifarotene, which is a RAR gamma receptor agonist, and this is already being looked at as a potential treatment for post-inflammatory hyperpigmentation. And there's a study that is in a phase 4 study that is ongoing right now, and so we look forward to seeing results of that. But beyond the retinoids, we also have other agents that can help us with the management of acne and PIH at the same time, most notably azelaic acid, which, as you all know, comes in 2 formulations, 15% or 20%. With respect to the management of PIH caused by acne, the data we have is not huge. We really have one open label study using 15% azelaic acid in a 16-week study by Leon Kursich and colleagues. And in this open label study, 31% of patients had resolution of PIH by week 16. But clearly we need more data to support the use of our agents for PIH. But this is what we have. And anecdotally, leveraging full face treatment approaches that manage both acne and PIH give us good outcomes, especially with the retinoids. And people often ask, well, do you use actual bleaching agents like hydroquinone, for example, to treat PIH induced by acne? And at least in my practice, I rarely use hydroquinone for acne-induced PIH because the lesions, the hyperpigmented macules of acne tend to be small. We have 3, 4, 5, no more than 5 millimeters, and difficult to spot treat with hydroquinone. And I don't like to use hydroquinone to the whole face since it could lighten one's overall complexion. So I prefer full face approaches with topical retinoids plus minus topical azelaic acid. We may also add adjunctive therapies like chemical peels, superficial chemical peeling agents, such as salicylic acid peels as shown here, or glycolic acid peels as a when I'm treating acne-induced PIH, I favor salicylic acid because of its lipophilic nature of salicylic acid. It does have some comedolatic properties. It's a good fit for acne-prone skin. However, a nice study published in India looked at the safety and efficacy of glycolic acid peels ranging in concentration from 30% to 50%. And what they found is doing a series of glycolic acid peels in conjunction with a modified Kligman-Willis formula for skin lightening. The group that got peels plus topical bleaching regimen did better than the group that used the topical alone. So giving us some evidence for the additional benefit of superficial peeling. When it comes to peels, though, it's a sort of a two-edged sword when talking about peels in richly pigmented skin, because while they may be very helpful, if we are not careful, we could induce excessive epidermal injury that could in turn lead to pigmentary complications. So to stay out of trouble, limiting ourselves to superficial peeling agents, including the two that I mentioned, salicylic and glycolic, but also Jesner's peel would be acceptable, as well as some of the modifications of Jesner's that are available on the market. One key thing for safety is discontinuing retinoids 1 week before the peel. The few complications I've had over the years have been in the context of a patient who's forgot to stop the retinoid prior to the peel, or used some other exfoliating treatment prior to the peel. And then you end up sort of overshooting your goal and ending up with potential erosions and crusting and subsequent dyschromia. And always start low and work up slowly is key. The next important issue to address when talking about acne and richly pigmented skin is that patient expectations, that what they are looking for, their endpoints may be a little different than our traditional endpoints. So the patient might perceive that their therapy is not even working at month 1, month 2, maybe even month 3. And that is because while we know that we can do a pretty good job of reducing papules, pustules, comedones, other active lesions of acne within let's say 8 to 12 week time frame, the PIH takes longer. And so while in a clinical study, someone like this who just has 2 papules might be considered pretty, just about clear, almost clear. But in the real world, this would be a patient who might not be satisfied yet because they're still covered in PIH. In fact, if they haven't been counseled appropriately, they might think that the treatment caused the PIH. So it's important to go over that in the initial consultation as far as what to expect. So scenarios like this can happen. Patient comes back, 8-week follow-up in this case, doing pretty well as far as reduction of papules and pustules and comedones. Most of us would say this patient's doing great, but the patient might be thinking, you know what? I don't even know if it's working. I still see my face is still uneven. It's got dark spots everywhere. And so I'm not sure if I agree with this dermatologist. So it's really until you get further on down the road, maybe at the 6-month, 8-month, 12-month mark before we have that satisfaction of being clear of both acne and PIH. So that extended timeline needs to be addressed right from that initial consultation, so the patient can be confident that they should adhere to their treatment and understand when to expect realistically that they will reach the desired endpoint. So setting those realistic expectations is really key. A third important area when it comes to acne in richly pigmented skin is that given that we have this sequela of post-inflammatory hyperpigmentation, and there's a higher risk of keloids and hypertrophic scars, especially for the more moderate to severe acne, especially if it's involving the trunk, and then even just atrophic scars, when they do occur, because of the higher risks of our treatment modalities for acne scarring, it's more of a challenge to treat them when they occur. So ideally, we would want to treat our acne early and effectively to avoid these sequelae to the best of our ability. And I think that's really key. And one concept is treating not just what we can see, which is the inflammation clinically, but this also subclinical inflammation lurking beneath the surface, like a slow burning fire beneath the skin. This concept was first introduced in the small study of 30 African-American female patients with acne who were biopsied, and even in clinically non-inflammatory lesions, so even in comedones, there was histologic evidence of marked inflammation that extended well beyond the lesion. Subsequently, in a UK study that was not in richly pigmented skin, but nevertheless shows the importance of subclinical inflammation. In this study, interleukin-1 and CD4 positive T lymphocytes were seen, and to a greater extent in perifollicular skin of acne patients compared to control. So even in uninvolved skin, clinically uninvolved skin in an acne patient, you can see the T cell infiltration around the pilosebaceous unit compared to the control who does not have a history of acne. So how can we address this inflammation? Thankfully, many of the agents that we already use have some anti-inflammatory properties, including the retinoids. Our antibiotics, we all know their anti-inflammatory potential. Other agents that we might not think about top of mind as having anti-inflammatory potential would be our anti-androgen therapies like spironolactone or clascoterone, topical clascoterone, which was recently approved in the United States. And the way that clascoterone works is that by blocking the androgen receptor, we may reduce cytokine production by sebocytes. So in this way, even though we think of it as primarily an anti-androgen therapy, which it is, it does, the downstream consequences are that we reduce inflammatory mediators. So it's been shown in vitro that clascoterone and spironolactone, for that matter, shown in this study, that there's inhibition of inflammatory cytokines in cultured sebocytes from clascoterone, and it was to a greater extent with clascoterone than spironolactone. So what does this mean with respect to treatment? So let's use this patient as an example. The desire here is to, have a comprehensive combination regimen that addresses multiple pathogenic factors, such that we can reduce the clinical and subclinical inflammation, and reduce all of these visible inflammatory lesions, as well as the inflammation that can't be seen, in an effort to avoid or reduce at least the frequency and severity of some of the sequelae. So this patient also had a sort of a deadline, in that had an important social event 4 months down the road, and so really wanted to do everything we could to get a fast result. Now, could she have been put on isotretinoin? Yeah, that might have been a great choice too, but I think that with the requirements for iPledge that we have in the United States, she wasn't able to get on that too quickly. So using everything but isotretinoin here, topical retinoids, including adapalene benzoyl peroxide in a fixed combination, topical dapsone in the morning. Doxycycline was used given the number of papules and pustules. She did report menstrual flares of her acne, so spironolactone was also included. For rapid reduction of some of the more inflamed lesions, intralesional triamcinolone was used. And 4 months, we've got very significant clearing of her acne. Residual acne scarring, you see those atrophic scars, and some residual post-inflammatory pigment changes, which can be worked on with chemical peels, or simply just tincture of time of ongoing use of a retinoid will take care of it in time. Now, I've just said that using multiple agents in combination is really key. Using systemic agents, I didn't say, but I will say that having a lower threshold for oral agents is in my opinion, useful when considering the need to avoid these sequelae. But despite saying that, it turns out when we look at how these prescriptions are written, at least in the United States, there appear to be racial and ethnic disparities in access to frontline therapies for acne, and a lower odds of patients who are Black receiving isotretinoin. And this has been shown in several studies. Not only isotretinoin, but also other agents that we frequently turn to are topical retinoids, adapalene and tazarotene, for example, versus white patients being prescribed much less in Black patients in the US. Another study, this one published in JAMA Derm, similar findings with respect to isotretinoin. Non-Hispanic Blacks were less likely to receive a prescription for isotretinoin. It also was shown in the study that they were less likely to receive oral antibiotics and spironolactone compared to their non-Hispanic white counterparts. And so the reasons for these racial ethnic disparities are complex and require further study. And but I'm happy that these studies are out there to highlight the disparities so that work can be done to reduce them. And it's very unfortunate and disappointing and upsetting that isotretinoin appears to be less frequently used in patients of color, in particular Blacks or African Americans, given its utility in really creating the ideal outcomes. Reduction of all the active lesions and ultimately resolution of the post-inflammatory hyperpigmentation, as in this example. So fourth important concept with respect to acne in richly pigmented skin is maximizing tolerability and avoidance of irritation, in other words. This is an example in the photo of a patient who started tretinoin 0.1% cream, used it a little bit with a heavy hand and maybe didn't hear all the directions that were given in the office, and now is calling the office with this irritant dermatitis, which in turn will leave some pigment alteration, which is now a new problem to deal with, iatrogenic post-inflammatory hyperpigmentation. So how do we avoid this problem? Well, we have to think very carefully about, while we're trying to maximize the efficacy of our regimen, we can't do it at the expense of tolerability. And so we think very carefully about the active ingredient, the concentration, the vehicle. And the good news is that any of the agents that are approved for acne, that we currently have for acne, as shown in this table, have been studied in Fitzpatrick types 4 through 6. They've included patients with Fitzpatrick 4 through 6 in their studies. So there aren't any contraindications per se, but we have to think carefully about, all right, what is the specific molecule and its tolerability profile? What concentration, if there are options, can I use to maximize tolerability? If there are vehicle options, picking one that has a more tolerable vehicle. Dosing regimen, starting every other night for retinoids and moving up to every night after 2 weeks that's tolerated would be a very prudent practice to maximize tolerability. And then the importance of concomitant skincare. Don't let the patient leave without any guidance of what cleanser to use and moisturizer to use in conjunction with the prescription therapy. We thankfully have newer options that with sophisticated formulations and vehicles that offer greater tolerability. Of course, not everyone has access to these for cost reasons, but when possible, these are great additions to our armamentarium, including this particular product, tazarotene lotion, which has been studied in diverse patients with good tolerability. The last area I'll highlight as a nuance in acne in richly pigmented skin types is that there may be some skin and hair care products that are often influenced by cultural factors that some of which might contribute to acne, and maybe agents that we need to advise patients to stop or modify their use. One example, at least in the United States, African American community, it's a widely held perception that cocoa butter evens the skin tone. It's good for scars, and I'm sure well outside the US that is thought as well, because if you go to the internet and look for remedies for scars and hyperpigmentation, you see plenty of mentions of cocoa butter. However, when we go to our peer-reviewed medical literature, we don't see any evidence for cocoa butter helping hyperpigmentation. We do see studies that show its comedogenicity, though. And so in this particular context, if a patient is turning to a product like cocoa butter for treating PIH, of course, this is where we can, in a culturally competent way, in a sensitive way, advise them that, there may be better skincare for their acne-prone skin and better prescriptions that we can offer that would address the PIH caused by acne, such as topical retinoids. Then, of course, there's acne that can be exacerbated by comedogenic hair care products, such as in this example with comedones, predominantly comedones on the forehead and temples. And the usual culprits are the traditional thicker hair products that may have petrolata, mineral oil, lanolin, which can in some cases contribute some comedogenicity. And so patients can be advised to either modify how they use it, further away from the hairline, or consider alternatives that would be useful for hydrating the hair and adding sheen to the hair and manageability, such as silicone-based hair serums that contain cyclomethicone and dimethicone as alternatives. Another scenario that we do see from time to time, and we're more likely to see it in populations with richly pigmented skin, is steroid acne that is sort of occult and it pops up in a way that's surprising to both the patient and the practitioner, in that the patient has no idea that they are using a steroid, and they come with the chief complaint of a major breakout that has just erupted out of nowhere, not having a prior history of acne often. And then you look carefully and you see some areas of hypopigmentation. You see a sort of monomorphic morphology of the papules to some degree. And then you ask the patient, please bring in everything that you've used in the past few months. And I think that's the best way to ask. Don't start asking whether they use bleaching creams, but just sort of ask them to bring in a bag everything that they may be in the medicine cabinet or at home that they've used in the past few months. And you may find products like this that are sold without a prescription, but have as their active ingredient potent, ultra potent topical corticosteroid. And so in a culturally competent way, we want to advise the patient to stop that, and then again, give them the strategy to treat their acne and PIH in the best possible way. So take-home messages, we want to align our endpoints with the patient goals. That means treating both acne and PIH, resolution of both acne and PIH being the goal, and provide realistic timelines for that. We want to initiate combination therapy that's highly efficacious. Do not undertreat. The consequences of that include the pigmentary alterations and the higher risk of hypertrophic scars and keloids. So everything we can do to start early and effectively. We want to maximize tolerability and consider some of the culturally influenced skin and hair care practices that might contribute to acne. And we have summarized this topic in a recent publication in the JDD, and I leave that reference here. And with that, I'm happy to turn it back over to Dr. Lind.
Thanks very much, Andrew. That was a great synopsis. We're going to leave the questions to the end. I'm going to just give a few last kind of comments here, and then we'll have the question and answer period, because I'm sure you've got lots of questions for Andrew. So just recognize, as Andrew said, recognize your goals. You want to get rid of the acne. That's why people are coming to see you, but recognize the post-inflammatory hyperpigmentation is often the thing that patients want, and they want that just as quick as possible. And recognize in these populations, there's more of a chance for keloidal changes, and certainly you recognize that those are often difficult to deal with. So post-inflammatory hyperpigmentation, more of a concern. You saw the studies that Andrew quoted there. Recognize that mild acne, again, can demonstrate marked inflammation, causing some more post-inflammatory changes. So it's about tolerability. Recognize again the keloidal changes, and prevention is the key. So treat early and be aggressive. So as far as I'm concerned, you don't have to wait for a failure of a topical retinoid or a regimen that has doxycycline or minocycline, whatever else. And again, recognizing that you want to prevent that post-inflammatory hyperpigmentation and you want to prevent those keloids that might go. So be aggressive in point of taking on and placing them on a isotretinoin, but go slow with the dosing, because there's a risk of keloidal changes. I can remember early on in the days when isotretinoin came on to the market, particularly the Germans were using high dose, 2 milligrams per kilogram, and basically they got a lot of acne flares, particularly if people had not been on oral antibiotics prior to that. So again, thinking about tolerability, go slow, and as Andrew said, you can potentially start every second day. I prefer to use a low regimen, even starting with 10 milligrams of isotretinoin, moving up to 20, moving up to 30, 40. I've always been a fan of not kind of overdosing people. I would prefer to use my dosing at a longer period of time and going to my endpoint of clear rather than inducing some of these other keloidal potential changes. Sorry. So one of the things I thought we would just address quickly, with the regular isotretinoin, high-fat meals, and this is what high-fat meals. I actually, when I was a resident at the University of British Columbia, was one of the quotation marks sub-investigators in the studies with isotretinoin. This is what you had to basically. We had pictures that we showed people. This is what you got to eat in the morning, because you got to get that stuff into your system so it can work for you. Most people, adolescents, go, hey, I don't eat that. I like eating grease, but don't think. And again, recognize that many adolescents skip breakfast. Again, 25% consume ready-to-eat cereals, lower intakes of a dietary fat. So we've often said, take it with yogurt, milk, cheese, but is there a consideration of lactose intolerance? And I'll talk about that in a minute. Certainly, fatty meals without dairy can be achieved with peanut butter, avocado, eggs, and meat, but dairy is often the one that most of us talk about. Luckily, we have a molecule, the Purus, using this light dose technology at our hands that gives you oral absorption. I think many have already seen these in the non-fasted state. When taken with a high-fat meal, the Purus was equivalent to absorption with Accutane, so the two we have. But in the fasted state, the absorption of Purus was approximately 83% greater than isotretinoin. And obviously, this turned into working better for our patients. The Purus, again, as I mentioned, go slow, pick the right molecule, pick a isotretinoin, and I particularly like Purus. But we have the individualized dosing. You can start with a 10, move it up to a 20, move it up to a 30 and a 40, and even higher if you so wish. Move on. And again, increased prevalence of lactose intolerance. Is it a myth? More research. I went looking for this specifically. And again, results from systemic and scoping reviews imply there is insufficient evidence to support this. However, if you go to Google, Google says that lactose intolerance is closely coupled with race. And again, likely to be self-reported than really having a true formal diagnosis. So how do we combine the evidence with public perception? Well, I'm not sure. Something to remember and talk about. So as I mentioned, Purus, this form of isotretinoin, has a high efficacy. No fat is necessary. Again, that individualized dosing, and there's no difference really in terms of the safety profile with this drug versus regular isotretinoin. And luckily in Canada, I think we're lucky that we don't have the eye pledge. Andrew was saying in that particular case that young lady wanted to be clear very quickly. Well, basically you do your blood work, have it back in 3 or 4 days, and you basically can pretty much start this. You don't have to go through a lot of other red tape, and that's very good. Again, tolerability, and I often tell my patients I have plan A. My plan A basically is to get rid of your acne, and then you're not going to have a lot of post-inflammatory changes by doing this fairly aggressively. And those that you do have, we're going to go to plan B. And after the fact, we're going to use your retinoids, we're going to use your chemical peels, or whatever to try to decrease that post-inflammatory changes. I do, however, think about the tolerability. So although I don't use a retinoid at the same time I'm using my isotretinoin, I do always let all of my acne patients talk about what is the proper cleanser they should use, what is the proper moisturizer, so they get into this habit of using this so you don't get a lot of dryness and irritation that makes them want to use something that one is maybe comedogenic, but also contributes to more post-inflammatory changes. So don't discount mild acne, especially in skin of color. You've heard that several times, both from myself and from Andrew. Be aggressive in your treatment. Topical failure is not necessary for initiating isotretinoin. And I think most of us are beginning to understand this. And again, reducing the keto changes and the PIH and skin of color is the ultimate goal. There may be higher rates of lactose intolerance, again, accepted, but there may be other alternatives. And luckily, we have a purist that can provide us an alternative to potential lactose intolerance. So thank you. Thanks for listening to Andrew and myself. We'll go to the sort of question and answer type of period, but please ask us any of your questions. They can be through the question and chat. Maybe I think Roxanne Chabot has got all the kind of questions that have come in over the talk, and Andrew and I can start answering these for you. Absolutely. So thank you very much for listening. Roxanne.
So again, we'd like to thank our supporters, Cypher, for making this educational event possible. So we do have a couple of questions that have come in. One is, which chemical peels do you use the most?
Andrew, you're on mute.
Sorry about that. And I've now unmuted myself. Thanks for the question. So which peels do I use the most? So in this particular context, acne-induced PIH, my go-to peel is salicylic acid. I'll start with 20% salicylic acid, and then I'll work up to 30% as tolerated. I'll work up to that. The factors that I'll modify will be, well, how much do I apply? The length of time, the duration of application time is less important for salicylic acid because there's no neutralization step, it's self-neutralizing. But in any event, there is a minimum period of time that you've got to keep it on before it you get the desired result, and the endpoint being that precipitate, that white precipitate of the salicylic acid. And so I'll vary how much I apply and as with each session, and then work up to 30%.
Yeah, I must admit, Andrew, you like salicylic acid. I've just had more experience over my time period with glycolics, and I use kind of 30, 35, work up, and eventually I'll get to 70. As I mentioned, I do not do these peels at the same time I have them on the isotretinoin. I wait until after that course is over. Similarly, if you're starting a retinoid, I don't kind of do the whole mishmash all at once. I tell people I want to get your disease under control by using, in a person I'm not using isotretinoin, getting their disease somewhat under control, and then moving on to using the peel. My thinking on that is really from the point of view that use them both together. People may get kind of mixed up, if you would, and they'll see that initially you might get some increased pigmentation, and they're going to blame the peel and whatever else you're going, and then they're going to stop. I want to do it in a gradation process, but we all, as dermatologists, have a different way of doing things, don't we?
And to your point, Dr. Lind, there was that study that I quoted from from our Indian colleagues using glycolic acid peel. So absolutely a great option.
Another question, what is the place of OTC in treatment of acne, especially low-grade ones?
I'm sorry, Roxanne, I don't think I caught the whole question.
What is the place of OTC in treatment of acne, especially low-grade ones?
Why don't I start with that, Dr. Lind, if that's okay?
Okay.
Yeah, I think OTC, I think the role of OTC in the management of acne is really key, both before the patient sees us. Of course, we don't have control over that, but after patient sees us and we prescribe therapy, I think the OTC agents are very helpful adjuncts, especially using gentle hydrating cleansers and non-comedogenic moisturizer with sunscreen in conjunction with the prescription therapy. As far as OTC agents that contain, let's say, adapalene or benzoyl peroxide, I use those only in scenarios where the patient might not have access for cost reasons to prescription therapy. How about you, Dr. Lind?
Yeah, in my view, again, moisturizers, proper washes and everything else. However, in Canada, I'm sure it's in the same in the States, there's all kinds of OTC products that, oh, use this, much like your Dermavate, your clobetasol, have clear skin with it and everything else. I usually try to steer people away from it, other than the cleansers and the washes, saying, you know, there's a whole brand in Canada called The Ordinary. They've got different lactic acids and everything else. I've seen so much worsening of their acne, and people are, you know, trying one thing and they're listening to their, or seeing on their iPhone, this is the new rage today. They buy the stuff and it doesn't work. I basically say, you know, go to see your family doctor or see your dermatologist. Get on a proper retinoid, particularly the people with skin of color, because it retinoids. And many of the moisturizers have retinoids in them, and they might be kind of buying this, but in fact, they often have richly emollient type of things and produce more acne. So I'm kind of careful with all that.
Another question, is there any evidence of isotretinoin preventing PIH?
Andrew, I'll let you know that one. You're the academician.
It's a great question. Evidence for isotretinoin preventing PIH. I have not seen a study that has demonstrated that. It'd be great to design a study to show that. But in our anecdotal experience, the high degree of efficacy of isotretinoin in terms of managing the acne does seem to result in a more rapid resolution of the PIH. So I think the way I make sense of it all is if we're really effectively controlling the multiple pathogenic factors of acne, and then the inflammatory mediators have quieted down significantly with a very efficacious treatment like isotretinoin, we then in turn expect to see less and less PIH develop over time, and the pre-existing PIH will resolve in time.
Yeah, I agree with you. I don't know of a study, but it makes sense, right? You're decreasing that inflammation and you should result in less PIH. Do you generally, Andrew, do you generally do like I do, not have anything else on board when you're using the Purus or the isotretinoin?
Yeah, I do. I do it a similar way. I rarely have another prescription topical on board when I'm using isotretinoin. It's usually isotretinoin, just gentle skincare, and of course the moisturization, since they tend to get dry as a consequence. I guess the exception would be if there was a patient who's really concerned about the PIH and the time course for resolution, despite whatever counseling I might give. I might consider giving a topical agent just to address the PIH in that particular scenario, but that's not my routine practice.
When should you be adding azelaic acid to existing retinoid regimen?
So
When should,
I rarely do this. I don't, but you know, as Andrew likes his salicylic acid peels, I stay away from salicylic acid. Um, Most of my patients, again, often get irritated by the salicylic acid, so I'm trying to stay away from that generally.
I'm not sure if I heard the question correctly, but was the question azelaic acid or salicylic?
Yes, azelaic.
Oh, okay. So when to add azelaic acid to existing regimen? So great question. I really prioritize the topical retinoid. And so I would rarely, I just want to make it clear that I would rarely use azelaic acid in place of a retinoid, the exception being pregnancy, planning pregnancy, because obviously you can't use a retinoid in that context. But when to add the azelaic acid to a regimen that already has a retinoid, I would consider that if on follow-up I'm not seeing adequate resolution of the PIH, and while the acne is well controlled, I want to do something more for the PIH. I would add azelaic acid to the regimen, which of course will help to some degree on the acne, but I don't find it to be as efficacious as our other options for acne per se. That's why I consider it second line.
Yeah, one of the points I'd like to make though is with this Mastne, I use a fair amount of azelaic acid. I think it's less irritating than a retinoid. So, you know, you're putting this on to a person who is often wearing their masks for 8 or 10, sometimes 12 hours a day, then having a retinoid underneath there, I find using azelaic acid much less irritating. And it's kind of one of my go-tos with Mastne, particularly in patients of color.
What do you recommend for pregnant patients who have hormone-mediated acne, since they cannot have any vitamin A derivative?
For me, I use, again, benzoyl peroxides. For that, you get a little bit of bleaching. Again, azelaic acid can be used, Phoenicia in Canada. By the way, Andrew, we just have the one formulation in Canada of azelaic acid. It's been genericized, so it's not likely that your second foam is going to come to Canada.
I see.
So both of those are things that are safe during pregnancy. I truly in my heart believe that topical retinoids are, except for tazarotene, they're probably completely safe. However, you have that kind of black box in all the monographs and everything else. So I don't use it except in a few cases.
Yeah, I agree with you, Chuck. I would just add, so you mentioned azelaic acid, I agree. Topical, this is one instance where I might use topical clindamycin, given that it's pregnancy, using the old system, at least the FDA's old system for pregnancy safety, category B. So I'm comfortable using the safety of that.
Another question, I've had a few patients with richly pigmented skin complain of enlarged pores while on isotretinoin. To my knowledge, there is no evidence for this in the literature, but some patients report it online forums. Is this something you've seen in your practice?
So enlarged pores while on isotretinoin, not something that I've actually observed or had patients complain of. How about you, Chuck?
Yeah, I've not observed it. However, I've had patients complain. And you know, these are usually the obsessive compulsives that are looking at their face under the 300 watt bulbs and in their bathrooms and looking at every type of thing. I've had a number of people complain about nurses in particular that do have to wear masks long periods of time, that they have linear scars, quotation marks, while they're on this. And I think that's probably somewhat of a reality because the pressure, and often if they're metal, is inducing a bit of irritation in the skin. So it's something to be aware of. I usually tell them, you know, we're trying to help you overall, and this doesn't really induce scars. It's what's happening because of the mask.
Sorry?
I was just going to say that maybe additional skincare to protect the barrier in that particular context might help reduce that. I myself have PIH right on the bridge of my nose just from wearing N95s all the time. But if in the context of isotretinoin, I'd probably be more sensitive to that. And so from the injury of the friction of the tight mask. So I think this is an area where good skincare recommendations would be helpful too.
What kind of system, if any, does Canada have to prevent screen pregnancy in patients taking isotretinoin?
Roxanne, do you want to go over that one again?
What kind of system, if any, does Canada have to prevent screen for pregnancy in patients taking isotretinoin?
They really don't. That's we don't have an iPledge program. I mean, basically, you have to read the monograph of the isotretinoin. You have to be aware of this, but you're free as a physician to prescribe this, and you're supposed to adhere to kind of two forms of pregnancy prevention. Continue to monitor the pregnancy tests during the treatment, usually on a monthly period, and for 1 month after they go off of the isotretinoin. But otherwise, like Andrew was saying, we don't have troubles. You know, you kind of write your script when you basically you get back here that they're not pregnant and that their blood tests are fine. You write it, they go to the store, they buy it, and that's it.
Must be nice.
Yeah, and also for me, you know, are basically for most people now, I'm seeing people every 2 months. We're doing pregnancy tests in women every month, but see a lot of them every 2 months. If you've got somebody, if you have somebody that you feel that maybe goes on and off and may go on and off their birth control pill, not totally reliable, first of all, I try not to put that person on in the first place. But if you have some extra concerns, then I would be seeing them on a monthly basis. They don't get another script until basically I've seen them and have their pregnancy test in hand.
A great question. Can a patient have acne and rosacea concurrently? And if yes, which is to be treated first? Sometimes it's tricky to differentiate one from the other in skin of color.
Andrew, you want to take that one?
Sure. Yeah, I do. There are instances, indeed, I agree that there are instances where there are features of both conditions. You know, one of the ways we usually differentiate rosacea from acne is whether or not there are comedones. But there, you know, from time to time, there is someone who truly has acne vulgaris, but seems to have a component of rosacea manifesting with sort of the erythematotelangiectatic type of features. And so treating concurrently is what I do. Of course, it is a challenge because some of the agents that we use for acne may cause irritation in a rosacea patient. So I think this is an area where azelaic acid really rises to the top as a good agent to treat both conditions.
Yeah, and isotretinoin can help both conditions.
True.
So if you got a good regimen around the moisturizer and the wash and everything else, you can get away with it.
Yeah.
But I agree with you. I use a lot of azelaic acid in that particular case.
And one last question, your retinoid of choice for maintenance?
I'll let Andrew answer that one.
So a retinoid of choice for maintenance, that is really individualized. I don't have one preferred retinoid for, you know, across the board patients for maintenance. It really is which retinoid got the patient the outcomes that we were looking for, and then I keep them on that for maintenance. So it's really individualized, and it's based on their results, including not just the efficacy side, the tolerability, of course.
Yeah, I'd agree with you. I must admit, I've just been in practice a long period of time, got used to using adapalene, and it's well tolerated. People can use it. They can begin using it 2 or 3 weeks after you stop the isotretinoin. I also found a cleave, the triferritine, also useful, but it's some people can't afford that. There are studies going on, as you mentioned, to look at this. So I think maintenance is important after you've treated them. You're trying to, again, remodel any mild scarring that they may have in their skin, both from the PIH point of view and any little scars that they might have. And also, I think, to help prevent further outcomes of acne in the patients. So I think, you know, you have to, I always teach my residents, you have to have a number of options up your sleeve, because sometimes you get people that, you know, that they didn't use stevia properly, and they used it for 2 days and washed it off after an hour or something. I didn't get any effect or something. There's no sense arguing with them. You go, okay, then I've got a different retinoid, and it's going to be more gentle on your skin and that type of thing. I find there's no sense arguing with people because they'll always say, of course I did it right.
Well, that's all the time we have together this evening. We'd like to thank Dr. Lynn and Dr. Alexis for an excellent presentation and so clinically practical to treat acne in richly pigmented skin. And we'd like to thank you all for joining us this evening. Good night, everybody.
All right, take care. Thanks, Andrew. Take care.
Thank you, Chuck.
All right.
Thank you.